The APPY Trial, a landmark in pediatric appendicitis risk assessment. Welcome to today's episode, where we explore one of the most impactful studies in pediatric emergency medicine, the APPY trial from 2018. This landmark research focuses on predictive scoring for appendicitis in children and adolescents, and its findings have significantly shaped clinical pathways in emergency departments across Canada and beyond. Let us begin with a quick overview. The APPY trial, also known as the Appendicitis Acoustic Diagnosis Pathway Study, was a prospective, multi-center investigation conducted at Canadian pediatric emergency departments. The central aim was to create and validate a clinical prediction rule, one that could accurately identify children with abdominal pain who are at low risk for appendicitis. By doing so, the study sought to reduce unnecessary computed tomography scans, thereby minimizing radiation exposure for children. Now, let us dive into the key details. This trial was published in the May 2018 issue of JAMA Pediatrics. The researchers enrolled 1,415 children and adolescents, all between the ages of 5 and just under 18, who presented to the emergency department with suspected appendicitis. The primary objective was clear: derive a highly sensitive clinical prediction rule that could pinpoint patients at very low risk of appendicitis. The result was the APPY score, a II-stage predictive model that combined patient history, physical examination findings, and routine laboratory tests. Here is how it worked. In the first stage, patients were classified as low risk if they met 3 specific criteria. The first criterion was that the absolute neutrophil count had to be less than or equal to 6.75 times 10 to the 9th per liter. The second, there could be no maximal tenderness in the right lower quadrant during the physical examination. The third, the patient must not report feeling nauseated. For those who met all 3 criteria, the model then recommended an abdominal ultrasound examination. This brings us to the second stage. If the ultrasound was either negative for appendicitis or non-diagnostic, which is actually quite common with ultrasound, the patient was considered to be at very low risk. However, if the ultrasound was positive, the patient would be moved out of the low-risk category for further evaluation. Let us highlight the main findings. The APPY score demonstrated remarkable sensitivity for those in the final low-risk group, meaning they met all 3 criteria and had a negative or non-diagnostic ultrasound. The model achieved a sensitivity of 99.6%. In simple terms, it correctly identified almost every patient who did, in fact, have appendicitis, missing only a very small number. Another important result from the study was its potential to reduce the number of computed tomography scans. The researchers found that if this clinical rule were applied, nearly 45% of low-risk patients could have avoided a computed tomography scan, without sacrificing patient safety. This is a substantial benefit, as it significantly reduces radiation exposure among children, which is especially important given the increased lifetime cancer risk associated with medical imaging. What about specificity? In this context, specificity was measured at around 40 to 50%. This is expected and considered acceptable for a tool designed to rule out, rather than confirm, appendicitis. The APPY score's purpose is to safely identify patients who do not require further imaging, while ensuring that those at higher risk are properly evaluated. The clinical significance of the APPY trial cannot be overstated. It introduced a validated, evidence-based approach for triaging pediatric patients with abdominal pain. This supports the medical principle of as low as reasonably achievable, particularly when it comes to radiation exposure. The APPY score has now become an integral part of clinical pathways for appendicitis, guiding clinicians as they determine which patients can be safely observed, which should receive an ultrasound first, and which are at high enough risk to warrant direct computed tomography imaging or even surgical consultation. Of course, there are limitations to keep in mind. The APPY score is a rule-out tool. It helps exclude appendicitis in low-risk patients, but it does not confirm the disease. Its effectiveness also depends on the availability and quality of emergency ultrasound, which can vary from one institution to another. Finally, because the study population was strictly children and adolescents, the findings and specific cutoff values may not be directly applicable to adults. In summary, the APPY trial developed a straightforward yet highly sensitive prediction rule that uses 3 key elements: the absence of nausea, the absence of right lower quadrant tenderness, and a normal neutrophil count. When these are combined with a negative or non-diagnostic ultrasound, this pathway can safely reduce the number of computed tomography scans by almost half in the pediatric population, all while minimizing radiation exposure and maintaining patient safety. Thank you for joining us on this deep dive into the APPY trial. Stay tuned for more evidence-based discussions that inform and inspire better care for our youngest patients. It's the Everything Surgery Podcast. Dissect the extraordinary.